Welcome back, listeners. My guest today is Laura Iosue. I have interviewed Laura before, and I do highly recommend that you go back and listen to that interview if you have not heard it already. Laura is a litigator with 30 years of experience. Some of the areas of her practice are now focused on professional attorney discipline and licensing and criminal defense. She represents her share of healthcare professionals in some sort of trouble, an accusation of drug diversion being one of those reasons that she may be representing them. I want to welcome you back, Laura.
Thanks. Thanks for having me. It's great to see you as always.
Absolutely. I asked Laura back because she does work that is not typically seen by people in similar positions as myself. And I think it's good to understand a bit about what that side of things looks like, especially if you are someone who is involved in interventions and interviews. And when you're talking to that healthcare professional, you are very much in a position to give them, not legal advice, but to tell them what they could expect next, or to encourage them or let them know there are people out there like Laura that can help them. So that's why I wanted Laura back, and to talk a little bit more of the legal side of things. So what might it look like after we identify a healthcare professional with a substance use disorder who's diverting from a hospital, and then we report them to the licensing agency? I want to start with something, Laura, you said to me previously when we talked, and that is, when do you need to report to the board about some action? And I don't think you meant when does the facility need to report to the board. I think it related to the healthcare professional that has a substance use disorder. When do they need to report? So what does that mean? What does that look like?
So that is such a good question. And it's something that I've just recently came across with two new clients. In talking about the hospital and advice about what things might look like, one thing that I think that nursing supervisors or HR, they need to be very cautious about giving legal advice.
Yes.
Because last week, I had two new clients who were given legal advice by their supervisors that was wrong. And that legal advice was, you need to report this to the board. And they're wrong. So in both cases, one, it was an allegation of a HIPAA violation. But the other one was a diversion, an allegation of diversion. And both of them were told by their supervisors that they needed to report it to the board. And in Indiana, that is not the case. Okay. So, and I think I touched on this somewhat in the last podcast that we did, is that in Indiana, we have a system that is different than most states, and it kind of matters, it kind of doesn't matter. In most states, it's my understanding that in most states, the board of nursing or the board of pharmacy or the medical board, they have their own team of investigators who will then investigate, and then they have their own legal team that would, then prosecute cases before the board. That's how attorney discipline is here in Indiana. But with medical, it is not like that in Indiana. In Indiana, the boards are administered by the Indiana Professional Licensing Agency, IPLA. But investigations and decisions about whether or not a case is going to be prosecuted is done by the Attorney General's office here in Indiana. And there was a case that got a lot of attention here in Indiana about a doctor earlier this year, and it was critical to note that it is the Attorney General's office that makes that decision. So what I would advise people to do is, first of all, the hospitals or supervisors should not be giving that advice.
Okay.
But when a person, is accused of diversion at work or anything else at work, if they don't know if they need to report anything to the board, then the best thing they can do, there are two things they can do. One, in my opinion, find a good lawyer who can tell you what to do, right? I mean, yes, am I biased? Sure, absolutely. However, and I've said this to you before, Terry, people don't come to lawyers because things are good, right? Absent an adoption or a business acquisition, it's not because things are good. It's because something hit the fan, right? Well, getting accused of diversion and losing your job, guess what? It's hitting the fan. And so if you think you need a lawyer, you probably do, right? Okay, that's the first thing. But if that's not an option because of finances or whatever else, go on to your state board's website, and there should, just look at it, and there should be something in the menu about statutes and rules, and read it. Take a look, and it should say, there might be FAQs, but if the statutes and rules are there, look at it and see if you think you need to report it. Okay? Because some states may require that if you're terminated, or if you're accused of diversion, or if you check into a place, if you seek treatment for substance use, there are some states that say that is something you have to report to the board. Indiana, that is not the case. In Indiana, the only things that you have to report to the board is if you are convicted of a felony or a misdemeanor, other than a driving offense, but OWI is a driving offense, but you would still have to report it within 90 days of the conviction, not charging, but a conviction, right? So let's say that it's a drug diversion and you end up getting charged criminally, okay, for the theft of the drugs, for whatever that's called in your state, right? Here it would be obtaining controlled substance by fraud, and generally there are a couple other things that go along with it for the falsifying the records or whatever, okay? You get charged with that, you still don't have to say anything to the board. Now, this is Indiana specific.
Right.
Within 90 days of conviction, then it has to be reported to the board.
Okay.
Now, other time that things have to be reported is when the practitioner renews their license. And there's always a series of questions on your renewal application. In Indiana, for nurses, I have to admit, and I think I said this to you before, they're not written very well. And nurses are confused all the time about what they actually need to be reporting. Because there are a couple of questions that do that. One is, since you last renewed, have you been arrested, charged, or convicted of any, felony or misdemeanor other than, I should have pulled up the questions before we started this, but, to me, that's a fairly obvious question. But still, sometimes people are like, well, no, I got a summons. I wasn't arrested. Right? So they answer that wrong. Okay. Well, then the answer is, okay, but you got a summons for what? A criminal charge, right? So still, I think that for me, it's really easy to say that because this is my language.
Right.
So I think there's a lot of people who really don't understand it. Right. But another question that is that trips people up all the time is, since you last renewed, have you been, it's something like disciplined, terminated, suspended from your employment, and that's really the question. Okay. Well, then the question becomes, well, I didn't think that I was, that was discipline. It was a teaching moment. And you know what? They're not wrong. Or I have someone else who, she said, well, it was unsubstantiated. So I answered no. Very often, as you know, when someone is suspected of diversion, they are suspended pending the investigation.
Right.
Well, is that discipline?
Still under investigation.
Right.
Yeah.
And the question, as it's written in Indiana, doesn't say suspended pending investigation. It does for other practitioners, like an anesthesiology assistant who I had. It asks specifically, but nurses, it doesn't. And, I even, had an interaction with the legal advisory to the board. And she said, well, she knew she couldn't go back to work the next day. And I said, yeah, but if that's what you want to know, that's what your question should ask.
Right. Right.
So, so my advice is, when it comes time to renew, read the questions carefully. Because and if that's what I say, just read the question carefully and answer as best as you can.
Legal stuff never seems to be straightforward, but then it's not, I don't speak that language at all. It's like, just talk English. Like, what are you?
Right. Don't expect me to figure out what you want. Why don't you just ask me?
Right. Yeah. Yeah.
So, but to me, if there are other boards that are asking the specific question and you're not, well, then you must not be looking for that.
Right.
Right.
Yeah.
So why should I have to guess to know what you're asking me?
Right. Yeah. I know when I renew my pharmacist license, there are questions on there, but nothing has ever happened. So I don't even know what it says. It's just like, nope.
Right.
But never had to think it through. Like, does this apply?
Right.
Yeah. So that's interesting. So in some states, if I'm just thinking, because I think what happens a lot of times is during the intervention, the nurse manager or director, whoever may say to them, I'm going to give you 24 hours to report before I report, because the facility is supposed to report, right? But they think that it will go better for the nurse if they report rather. So that might not really be the best
That is not my
to
experience.
do. Okay.
And this is a case that you and I talked about last time, in particular, that it makes, I recently had a nurse, and I know we talked about this. That nurse recognized they had a problem. Work did not catch them. They went to work and said, I've got a problem. They sought help.
Yeah, which is great.
Yeah. And it was a hospital system here, which is very good for second chances. They're like, you go get some help, and we're going to, we'll put you in a case management position. We're going to have you in EAP. We're going to do all of this. But as you said, they have to report to the board, right? Or, to the Attorney General's office. Well, in this case, this nurse was working at 2 different hospitals for the same healthcare system. Ended up and was accused of diverting from both. Had 2 consumer complaints, which is, the confidential under investigation complaint. Not only was their license investigated, but they got charged criminally in both cases. And I had to fight tooth and nail for this nurse to end up with misdemeanor convictions instead of a felony. Because if this nurse was convicted of felonies that related to controlled substances, they would automatically be placed on the Office of Inspector General Medicaid Medicare exclusion list for 5 years, mandatory.
Yeah.
And but if it's a misdemeanor, it's a permissive exclusion, which they still might get excluded, but they might not. And it's a 3-year guideline. So it was critical that this person get the misdemeanor. And and that was also prosecuted by the Attorney General's office here in Indiana. They took the criminal case instead of it going to the county, which is an option sometimes. And I believed that this person, and of course I am defense oriented, right? My client was never saying that they shouldn't have consequences, right? They knew they should have had consequences.
Yeah.
But this person's background was, they had sacrificed a lot for the community. And that sacrifice manifested in, I mean, this person had seen stuff that you can't unsee.
Mm-hmm.
And um, and so those mitigators were huge to me.
Sure.
And they were exposed to that kind of trauma in a different profession that was also a service industry, and then as a nurse.
Yeah.
And that person self-reported to their boss.
Which is big.
Huge. Why? Because they wanted help.
Right.
And that hospital wanted to keep them and did keep them.
Okay.
Moved them into case management. Was entirely behind them. And yet, the best that I could get, the best plea offer that I could get was open to argue to a misdemeanor conviction instead of a felony. And so I had to argue that in 2 different counties. And I'm very thrilled and happy for my client that both judges saw it our way, and that that person was then convicted of misdemeanors. So, but to me, I thought, geez, my client, oh, and the biggest piece, my client's been sober for like 2.5 years, something like that.
Okay. They've done the work.
Yeah. And, and that those clients, they're in caduceus groups, right? They're talking to other practitioners. So what possible incentive would someone else have to come forward?
Self-report. Yeah.
None. So unless the statutes mandate that the person self-report, I don't think they should. That's separate from getting help with their recovery monitoring agency, and we'll talk about that in a bit, I know. Because there are 2 pieces. There's the recovery piece, which is internal, right? That you have to do that. But then there's also your licensing piece.
Mm-hmm.
And, that's another reason that I think it's good to get a lawyer, because then a lot of, a big part of recovery, I'm not in recovery. I have never been diagnosed with a substance use disorder. And, but I know enough to get myself in trouble to know that, a big piece of recovery is accountability and making amends, right? So you feel like you're not being forthcoming. Is that going to impact your recovery? Well, if you hire an attorney, that's off your plate. Let your attorney worry about that.
Mm-hmm.
It's just, because that's for someone new in recovery, what I've been told is that's a really hard piece.
Yeah.
So just turn it over to your attorney and let them deal with it. Then you can focus on the other pieces.
Yeah. I guess on the one hand, it feels like the first step to recovery is admitting I need help and I need to get in recovery, but you have to be careful thinking a few steps down the line. It's not that your intention is to deny that you did it, but you want someone professional representing you and knows how to have that conversation and to go about that.
I think so.
Yeah. Wow. Okay. So I think part of what I'm taking away from this is that everybody needs to know what their state licensing requirements are. And then wouldn't it be nice if we were kind of all on the same page? I mean, I know from a legal perspective, defendants and plaintiffs, you wouldn't need both sides of the aisle if everyone would just agree on everything, right? But it would be nice if accountability was part of it, but not, I have to wonder what was going through the Attorney General's office's mind, whoever had that case, that they thought that they should really throw the book at this one, given all of the things that you had talked about.
I will have to say, in their defense, they could have charged my client with more, right? Because there were, however many instances, right? They could have charged them with every single instance,
Okay.
right? And they could have said, well, no, we want this person to plead not only to obtaining controlled substance by fraud, but also falsifying records and also,
Sure.
whatever, right? They could have done that, right? Um, and they didn't. So,
Okay.
to say throw the book at him, I feel like that, and that part of that is because of me that I kind of, played that up.
Okay.
But it just, to me, I really felt like, so there was that. They did show that kind of grace, right? That they said, okay, fine, he can plead to one in each county. I had to push for the alternative misdemeanor argument, right? Um, but
Yeah.
I just didn't think that it was fair
Right.
so for that. Although, did they completely throw the book? No, they
No.
didn't.
Okay.
They could have made it
Yeah.
worse. So
Yeah.
they weren't completely unreasonable, but in that aspect, I felt like,
Yeah.
come on, this
Yeah.
person this person is going to be talking to other
Right.
nurses and other practitioners. And to me, the fact that they self-disclosed
Yeah.
was a big mitigator.
Right. Is there now you're, like you said, you're always with the defense side. And so your goal is to always get it not to be criminal, I'm sure. But can you think of a time where if you took on a client where you thought or could think if, in the future, if you haven't had one already, it's like, okay, I can see why they're going for criminal and I'll do my best to defend that. But, they kind of deserve it. You know what I
Um,
mean? I know you're always trying to get them off, right? And help them
well,
through with accountability, but
um, well, I was with the Attorney General's office for, almost 7 years. And I was in a position where I, ran the team that investigated nurses and other medical professionals. And then towards like the last 2 years, also pharmacists and doctors and all that. But so I did have that aspect of it. Now, my team was not part of the AG's team that did the criminal prosecutions, because the only team that keeps the criminal prosecutions here in Indiana is the Medicaid Fraud Control Unit, and I wasn't with Medicaid Fraud Control Unit. And so I think it's my understanding, and I could be wrong about that some of those policies of the felony versus not felony come from the federal Medicaid Fraud Control Unit.
okay.
But I don't know the inner workings. I'm not privy to that.
Okay.
So, are there times, I can certainly appreciate the criminal prosecution, right? I mean,
so it's more of a checkbox. I mean, they did this, they did this, they did this, they fall under.
I don't know.
Yeah.
I don't know, because I have other clients who did the exact same thing.
Oh.
And they don't get that. They're not criminally charged.
Interesting.
Or, and I think we touched on this a little bit the last time, did the exact same thing, and their case, if they are criminally charged and it's handled by the county prosecutor, they go to drug treatment court. And in drug treatment court, it's intensive probation. And if the person completes it, I mean, really intensive with a drug treatment aspect of it, if they complete that term of probation, the case is dismissed. But if it stays with the AG, with Medicaid Fraud Control Unit, they won't let it go to drug treatment court. Instead, they want a felony. So for the exact same conduct, the county prosecutor is saying treatment, no criminal charge, no criminal conviction, which in Indiana, if you're charged with a felony and it is ultimately dismissed, it's also expunged. That's new in the past couple years. So you have that, which is dismissal and expungement and treatment, which I think helps everybody. And then on the other side of the spectrum, same conduct, criminal charges asking for a felony.
Interesting. Okay.
Even when it's the same hospital system.
Yeah. So we in my circle all know that we need some standards with policies and procedures from institution to institution within the same states, outside of, there needs to be some standardization, but it sounds like the legal system needs a little standardization as well.
Well, I think that is a conversation that is bigger than what we're talking about, right? Because really what you're talking about is, should things be handled, should those policies be handled at the local level? What are the local views on those things?
Yeah.
Versus a countrywide view.
Yeah.
And and that's a whole other political thing, right? And so if it's federal Medicaid fraud control unit making those decisions, that's a different policymaker, right?
Yeah.
But for a local county prosecutor, well, if the local community doesn't like it, they can vote them out. And so, I suppose you could say the same thing about, okay, you could vote out who's ever making the decision at the federal level too. But I don't think those changes happen as quickly.
Right. Well, then it comes down to judges too, then. I mean, what they decide to do.
Right. And, whether you're in a place that appoints judges or elects judges, okay, well, you don't like that this person, okay, fine, vote them out.
Right.
So, but the other thing that I think is important to note is, and this is also who the policymakers are, if the hospital where the diversion occurred, right? It's the hospital who had to file the DEA 106. It's right. Okay. If that hospital says, we want to keep this person, that ought to mean something, because if the person has a felony conviction, guess what? The hospital can't keep them.
Right.
And so, so to say, we want small government, and I'm going a little far afield here, right? But yet saying we're not going to let the hospital make that call.
Right. Yeah.
That doesn't seem right to me. I think if the hospital is saying, we think we would like to be able to keep this person.
Right.
I think that those policymakers should be listening to that.
Right. And it's this might be a really simple generalization, but if, let's say I was mugged and I decide I don't want to press charges, that's my decision, right? And then there is no legal case anymore because I'm not pressing charges. So it's
they could still, in a criminal case, they can still charge the person.
Even if I say, okay.
However, they would need your cooperation, the prosecutor, right? Because if the case went to trial, you would have to testify. And if you're not going to testify, you're not going to testify, right? So, and that's a whole other, thing, whether you subpoena the person, are they going to come out and if you were subpoenaed, are they going to send a sheriff out to come and get, all that stuff, right?
I'm just thinking if the hospital decides they want to keep them and is essentially saying we don't want to press those charges,
I think
I'd be done with it.
It should matter, right? Or not even dump it.
Just be done, like accountability, but like now let's move on. Yeah. Right.
I mean, misdemeanor.
Yeah.
That way we can keep them.
Yeah. All right. Well, it's you never know what's going to happen is kind of the bottom line, which is a little unsettling for somebody going through it.
Well, and so your question is, what is it going to look like? if they report it to the board, which I kind of think is where we started, but then we ended up way over here, which is my MO. But so the hospital is more than likely going to report it, right? The hospital is going to report it.
Yeah.
So I guess, the easy thing is, why do I have to report it if the hospital is going to report it, right? Okay. Other than that, accountability and amends piece. Okay, fine. But when the hospital reports it, the practitioner will get notice either from here in Indiana, it would be the AG's office, or in another state, the board. I have to warn you, Terry, I feel a sneeze coming on.
Okay.
And then I have big sneezes. Sorry. So the person will get notified that there is an investigation, and they will be informed of what the allegations are, and they'll have an opportunity to respond. Now, I think that at that point, I think the person should have a lawyer.
Okay.
And the reason for that is because that whole anything you say can and will be used against you in a court of law, well, this is one of those times.
Yeah.
While the investigations are still confidential, if it later becomes public because of a licensing complaint that is filed, that's when it's public. Okay, so now we go criminal. And if it's put in there that you said X, Y, if it's put in the complaint against the license, that in your response you admitted to blah, 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 well, now that could be used against you in your criminal case.
Sure.
So I think it's important to get a lawyer in those instances. And I will tell you that I am starting to say a lot less in my responses for clients than I used to.
Okay.
And I thought, and I was putting in a lot of mitigation before because I think it's important. I think that I have said this to you before, that when I was prosecuting these cases, I understood that people who end up with a substance use disorder, something must have happened, right?
Mm-hmm. Yeah.
That short-circuited how they process stress.
Right.
But I didn't realize just how severe people's trauma was and how long it lasted and how pervasive. I just didn't.
Mm-hmm. Yeah.
So I was putting in a lot of that. And I still but I realized it doesn't matter. It doesn't matter.
Yeah.
So I'm putting in less than I used to. And then if the person gets charged, well, I still have it. I can still use that as mitigation later.
Right.
But I think, so in any event, I'm getting off again. The practitioner will have an opportunity to respond. I think they ought to have a lawyer so that they're not telling either the board or the AG, whoever the investigator is, so that they're not telling that investigator information that is detrimental to the practitioner that maybe the investigator didn't know.
Okay. And is it safe to say that you feel the same way when a facility sits down with somebody? We're always looking for that confession. Would that fall under any of this, or is that different because there's no legal, it's just a different setting? Or would you still advise everybody to not confess anything? Let them report their suspicions, because we look at it as this is the beginning of how you can begin to get help. We'll give you the resources.
My only concern with that really is that I have some clients who have told me when they called me into that meeting room, I knew I was busted, and man, was I relieved.
Right. Yeah.
But then I've had other clients who were not diverting. They were bad at charting.
Right. Right.
right?
Yeah. Yeah.
Or they were in a critical care unit, and they were assigned 6 or 7 patients, right? It was bad charting. I have seen hospital investigators push and push and push and push and try to get a confession out of people when they didn't do it. So if the assumption is, oh yeah, if you were tagged, if the software, the pharmacy software pulled you up as one of the highest, pullers of whatever, then you must have done it.
No, there's other reasons,
There's
right?
other reasons.
And sometimes the data just doesn't. Sometimes it's fairly conclusive. It's like, oh, okay,
of course,
yeah. But other times it's like, I don't know. We won't know until we talk to them. And then you're hoping you get some, something when you're talking to them, either an alternate explanation,
right?
Or sometimes they can't give you an alternate explanation, but they put up the roadblock, and then you're like, well,
But sometimes not having an explanation, that's honest. Look, you're asking me about something that happened in July and it's now October. Yeah. I don't know. Right, and to expect that person to know, because I've seen this in these interviews, Terry.
Oh, yeah.
I've seen it. Well, why don't you know? Do you know what you were doing on July 29th at 7 p.m.? No.
No, yeah.
So to me, when you know?
Yeah.
The person who knows what they were doing on July 29th?
They're probably lying.
Or they know they were, well, yeah, it's because I was diverting.
Right. Yeah. Yeah.
Right. But if you don't know, I couldn't tell you why.
Yeah.
As a lawyer, I try to document everything. Right. Because anybody can file a complaint against me too.
Right. Right.
And so if I don't document it, I don't know. Well, if you already don't have time to document it, there's no way,
Yeah. Yeah. I used to keep my little book too when I was in patient care. If something weird happened, or I had to challenge a physician on some prescribing or, whatever, and then yielded to them because it was like, well, it wasn't one of those hard stop things. I just write it down so I have it if it ever came up again.
Right.
Yeah.
And for me, I get to sit here at my desk in my office, which is at my house, right? With usually my dog snoring next to me, right? And I have the time and the liberty to take my notes and put it all in my case management system. But when I'm triaging stuff,
right. Yeah.
Which is what some nurses' jobs are every day.
Yeah.
You're asking the impossible.
Right.
So whether or not the person should say something in those meetings, I always think the answer is no, because it doesn't matter. If you admit, they're going to file, in my experience, if you admit, they're going to file something with your licensing board or the investigator. If you don't admit, they're going to file something with the licensing board.
They may or may not, or they may file and, land on bad practice, can't rule out diversion.
Or they may file it and say it was diversion and charge the person with diversion. Charge the person, I've had that case too.
Oh, wow.
Charge the person criminally with diversion.
See, now it goes back to standardization amongst hospitals. It's like how and when. Yeah.
I mean, and I think that I think that there is too much asked of too few practitioners. It's an impossible workload.
Yeah.
And
especially these days, staffing shortages that we hear about. And
and I'm not convinced there's actual staffing shortages. I think it's a shortage of a willing to pay for staffing. That's my opinion. That is my anecdotal opinion.
Yeah. Yeah. Well, we do hear a lot about hospitals losing money and it's getting harder, but yeah, it's hard to
I mean,
know.
I just know from my own experience with my mother, who passed away about a year and 15 months ago. I think we've talked about this, that, we would be in the ER and they would say, oh, well, we have to wait for a bed to become available. And I would say, really? Something tells me that you have a bed available upstairs, that you probably have a whole wing closed off because nobody wants to pay for staff for it. But I bet there is a bed available, isn't there? And guess what would happen?
You would get a
Oh,
bed.
it became available.
And here's my card.
Every time. Every time, magically, a bed became available. Oh, someone was discharged at 10:30 at night, at 2 o'clock in the morning? I don't think so. I think the bed was available the whole time.
Interesting.
That's just my anecdotal experience with my dear mother, God rest her soul.
Yeah. Okay. All right. Okay. Well, this was an interesting discussion. I know we kind of, just did a bit of bantering back and forth, but I think it's good information for people to hear. To me, like, it seems so clear. Your goal is to get to the truth, always the truth, not to, force people into a corner to say something that, we hear about that with criminal cases and whatever, the law enforcement goes at them until they finally admit. But to get to the truth, but now this is kind of interesting take on it to reassess, and maybe the truth is still the goal, but maybe for them to at least admit and want to get help. So you offer those resources no matter what the outcome of the interview is, so that if they have like, oh, yes, I want this to be, over and get some help, they know where to go, as opposed to just be like, okay, if you're not going to tell us what's going on, then we can't help you. We'll be in touch. You're on leave until
that's not to say that the hospital can't say, listen, if you don't agree to go to treatment, we're going to have to terminate you. I mean, I can appreciate that too, because sometimes the person might need that push, right? But that's a person who actually needs to get treatment, right? So then what happens is the person goes, they get evaluated to see if they need treatment. And guess what? If they don't have a substance use disorder, there's no treatment to get.
Right. Okay. So instead of tell us what's going on, it's, we feel that. And so we want to encourage you to do this. And so here's how you can make that happen and start on that. Okay.
Right. I mean, I really think it's a case-by-case basis.
Absolutely. 100%.
Yeah.
Yeah. 100%. Yeah. Yeah. Because like I said, sometimes you go into that interview and it's like, I don't see any other way this can play out. This data is so compelling. And then other times it's like, well, this could be poor practice, but I need some sort of explanation as to why you're always doing this, right? So what's your process? And then you get another explanation, and then and then other times you're still left with, I don't know. I mean, it looks bad. They don't have any other reason, and they seemed a little cagey. So
I also think it's important for those doing the investigations and that interview that you're talking about. I think it's very important for those people to have done some kind of shadowing to know what's actually going on the floor. Because while there are all kinds of protocols about wasting and whatever, you know what? If the nurses and whoever are not actually following those protocols, if the culture is, oh, hey, will you sign that you saw me waste this? Mm-hmm. And that is true, right? 100%. I mean, that happens, right? Yeah. So, if and no one's going to admit that.
Right. Because they're afraid of getting it.
Right. Until they say, well, that's what everybody does. They come to me and they say, look, I'm telling you, nobody does that.
Right.
This is what we're supposed to do, but nobody does it. Why? Because we don't have time.
Right. Yeah, no, I agree. 100%.
So I think it's really important, that legal has great protocols on paper. But without knowing what it's actually like in practice, there's no way those protocols are going to be followed.
Right, right. Agree. And that's what I'm a big proponent of, accountability before you ever get to this phase. It's like, the managers of the departments need to know what the policies and procedures are. They need to make sure they're being followed. If they aren't being followed, they need to figure out what the barriers are.
Correct.
To see, are there bad policies and procedures that then we need to adjust? Or do we need to, like if you're supposed to waste at this location, but you don't have waste boxes, well then, how can they even begin to follow it? And there's a barrier. So I'm a huge proponent of definitely all of that stuff ahead of time before you get to the phase where it's like, okay, why aren't you following it? Because, everybody else is managing.
And there also has to be a culture where people are comfortable explaining why they're not following it.
Absolutely. 100%. Yeah. So we have a lot of work to do out there still. Some facilities are probably doing it well, but others probably
not. Of course some are doing it well.
Yeah.
You know?
Yeah.
But,
okay. Well, this was enlightening. I want to thank you for sharing that. I've enjoyed the conversation, and it's some great stuff. But I will tell you, we didn't get to our other topics. So this is what we're going to do: is we're going to have a part B, everybody, because I don't want this to go so long that listeners don't have time to listen to it. So we're going to sign off from this, and then we are going to be back with our part B, where we're going to talk about recovery monitoring agreements. Thank you, Laura, for your time.